In this segment, we will be discussing the basics of clinical examination in orthopedics. Like any other local examination, there are some prerequisites for the orthopedic examination. We have to explain each step of examination to the patient. We have to wear gloves throughout and take all safety measures for ourselves as well as the safety of the patient. Then we have to perform a general survey assessment, which includes a head to toe examination and vital parameters of the patient so as to rule out any gross abnormality. For lower limb symptoms, patients, we have to start with a gait examination and then we have to examine the limb in the position to which the patient is comfortable. Then after that, we have to start telling the attitude of the patient. That is, patient is sitting comfortably on the bed, lying, supine, or standing. Then proceed to the inspection. Here we have to tell what our finding is, what is its location, and what is its approximate extent just by visualizing, and whether it is well delineated or not, and what is the appearance of that finding. Here we have to describe the condition of the overlying skin and if there is overlying wound, sinus, scar, or ulcer. And, and we also need to check whether the swelling is a mobile one or a static one. The swelling may change its position or size according to the limb position and also according to the movement of the joints, and it may be pulsatile. So we need to check all these findings in our inspection. If there is scar, we have to comment whether it is a primary healed one or healed by a secondary intention, which would have an irregular appearance. The scar can be longitudinal or transverse depending upon its relation to the body axis or the limb axis. And if there is a wound, ulcer, sinus, then we have to comment on the type of wound, whether it is a lacerated wound, incised wound, or an abrasion. If it is an ulcer, then we have to comment upon the floor, edges, and margins. If the floor cannot be visualized, then we have to term it as a sinus and also comment on its edges and margins. Then coming to the palpation. In palpation, first thing we have to check is the temperature, and we have to check it by the back of our fingers because they are more sensitive to the temperature sensation than the palp. Then tenderness. We have to apply gentle pressure over the examination site and have to look at the patient expressions rather than asking whether the patient is having pain or not. Then the extent of the swelling. Here we have to confirm our inspectory finding by palpating the margins of the swelling. If we are not able to delineate the exact margins of the swelling because of poorly defined margins, then we can just tell about the approximate extent of the swelling. Then we have to palpate for the consistency of the swelling, whether it is soft, firm, or hard. When it is a soft swelling tissues like muscle, tendon, fat, etc. If it is firm, then it means some fibrosis is ongoing. And if it is soft to firm, then both soft tissues as well as fibrous tissue are there. If it is hard, then it is most likely containing the bone. Then we have to comment on the mobility of the swelling or scar or any other finding that we have checked in our inspection. If our finding is adherent to skin, then on mobilization there will be puckering of the skin visible, and if it is adherent to muscle, then it becomes taut with muscle contraction, and if it is adherent to bone, then it constantly remains in the same position. Fluctuation is done to check the fluid collection inside the swelling. Here we have to press one end of the swelling using two digits and feel for the movement of the fluid on the opposite side of swelling by two other digits and feel for the expansion. If the swelling is pulsatile, then we have to place two fingers over the swelling. If the space between the fingers is increased with the pulsation of the swelling, then the swelling is expansile. However, if the fingers are in same position and there is no increment in the space between those two fingers, still the pulsations are visible, then that means those pulsations are transmitted ones. Then coming to measurements, for non-circumferential swellings, we have to tell about the supra-inferior and mediolateral extent of the swelling. For circumferential swelling that are enveloping whole of the limb on all sides, we can tell about the supra-inferior extent and can measure the girth or circumference of the swelling and compare that with the normal limb. And then we have to measure for the limb movements, that is the joint movements, proximal and distal to the swelling. For wounds and ulcer, we have to tell about the length, width, and depth of the wound or ulcer, and diameter if they are round in shape. The limb girth measurement should be done in the mid region of the examined segment of the extremity. Like for thigh, we have to measure at the mid thigh region. In leg, we have to measure at mid calf region so that the comparative assessment can be done from the opposite normal side. Then we have to perform the neurovascular examination. Here we have to palpate for the distal pulses, and for cases unrelated to neurological symptoms, simple assessment in form of the intactness of distal movements like ankle and toe dorsiflexion and plantar flexion and the sensory function would suffice in case of lower extremity, and in case of upper extremity the dorsiflexion and palmar flexion of digits and wrist would be helpful. However, in cases related to neurological impairment, we have to perform a detailed neurological examination for sensory and motor functions. Then there are some special tests which are different for individual joints and extremities, and those will be discussed in subsequent lectures on the examination of hip, knee, ankle, shoulder, elbow, and wrist. Thank you.